Beacon Health and Fitness. Health happens here.
But I want to make a couple of distinctions before we get going, because there's really two camps of folks that I get concerned about. One camp would be who I would call the over-exercisers, a little compulsive, extremist type, right, who you might see more of here. And then, of course, there's my eating disorder folks, right? And I want to be really clear about the distinction that they are not the same. But when I talk about them, sometimes I kind of flip back and forth. And the reason why I flip back and forth is because this camp, people don't die in this camp, right? There's a lot of extremist, over-exercisers, compulsive folks out there that aren't dying. They may get stress fractures and problems and all of that. They may not be psychologically super healthy, but they don't die, right? But this camp of people, yeah, they die. Like, in fact, eating disorders, I don't know if you knew this, but eating disorders has the highest mortality rate of any mental illness. You know, like schizophrenia, suicide, eating disorders far surpasses all of it. Like, more people die of eating disorders than any other emotional, mental problem. So in my line of work, I'm kind of careful about these folks, right? So even though you may be one of them, or you may know them, or they may be in your family, or you may even work with them, I'm really careful about treading with those folks so they don't get here. Because once they get here, it's really hard. You know, people with eating disorders have a rough time of it. And people with eating disorders don't want to be there, right? They don't want to die. I've never known any person with an eating disorder that was like, you know, this is fine. They're desperately trying not to be stuck in all of this. So, but I always want to be careful about the distinction.
Can they be in both areas?
Usually, yes. Well, usually, I mean, it's sort of a continuum that it might start out, at least with exercise. Mm-hmm. You know, it might start out in this category. Once they cross over into the eating disorder realm, it's part of their symptomatology, right?
Can it go from that one to the other?
Oh yeah, yeah. There's a scale. Now, it's tough. You know, I would say most treatment centers around the country, once you've been in this category, their recommendation is, yeah, you don't exercise. You don't go to gyms. You don't do structured. I've never really believed that. I don't I don't practice that way. There are a couple of programs across the country that treat athletes, and they are doing a really good job of helping folks in this category be able, but they can't be over-exercisers, over-trainers, so they could never go back to this. They would get into what we'd call a healthy, you know, exercise kind of mentality. But it's hard, you know, because usually if you're an over-exerciser, compulsive, extremist kind of person and you develop an eating disorder, usually exercise for you is always a bit extreme. You know, it's really hard to rein that in because you tend to be more OCD anyway, more driven, you know, really perfectionistic. So it's hard to like rein that back in. So, but I want to be clear because I know sometimes when I'm talking to people that work in this realm, you know, of exercise and exercise science and all that it's easy to start being like, well, that's not so bad, or that's not deadly, and it's true, you know, that it's not, but we still have to be a little bit careful. And my guess is that one of the reasons why I'm here is because, you know, I would love for you guys to be able to discern sort of when is it like, okay, that's a bit much, but nobody's dying, right? And oh my gosh, like we need to intervene. This person, we're like, there's an ethical, moral dilemma here, you know, if we're letting this person continue. So to that end, I mean, I just want to give you some information, and then hopefully we can have a dialogue about like where it's tough and how do we navigate some of that. So just to get started, I don't know how familiar you are. I'm not going to do, like I said, the 2-hour like diagnostic thing. Go on any website, you know, or go on any, you know, computer and type in anorexia. I'm sure you guys are fairly familiar. But so anorexia is more characterized by restriction of food intake, and also what we like to refer to as a energy imbalance. So folks that struggle with anorexia have less coming in and more going out, right? Bulimia is characterized by the behavior of binging and purging. So folks with bulimia may be trying to be fairly restrictive, but they have a loss of control at times over food where they're eating And this is not just, oh my gosh, I went to Hacienda. This is like, I think the criteria is like 3,000 calories at one sitting. So it's truly binging. This is not normal overeating at all. But with bulimia, there is a purging or a compensatory kind of component, either through exercise. So some of those folks you'll see are bingers. They don't look like bingers. They're super fit. They're in shape. But they have this loss of control component, or through purging, through laxatives or throwing up, that kind of stuff. Binge eating disorder, exact same process, but no compensatory behavior. And we'll talk about weight stuff as far as that goes in a minute. Other related disorders, which I think are helpful, especially in your realm. In fact, I would guess these are the ones you guys are going to see more frequently. Muscle dysmorphia or body dysmorphic disorder is basically when you don't see what's accurate. So we're seeing more and more men with the muscle dysmorphia, which is targeted towards, it's actually about muscle development, and they see their muscles as less big than they really are. So there's this over emphasis and attachment to developing muscle, even though you're looking at them going, you look pretty muscular to me, but there's a dysmorphia about it. The body dysmorphic disorder is actually in the opposite direction. Those would be folks that don't see themselves as small. They see themselves as bigger than they really are. Another component of both of those is just a detachment from their body. Like there's just not much of a reality. They don't, folks that struggle with those issues don't even recognize pain in physical activity. So they might be like really going hard and they're red in the face and you're kind of worried, you know, like, are you gonna have heart? And they're just not cognizant of that at all, you know. And then orthorexia, you guys heard that term before. So another more sort of, I guess we're just defining it. It's been around for a while, but orthorexia is a focus on being healthy that is unhealthy. So it might start out as someone who says, you know, I want to be vegan, but they are like vegan with a capital V. Like, I don't touch anything, and it develops into more of a compulsive obsession of, you know, asking, you know, food servers, you know, how did you prepare this? Did it touch anything else? You know, so it starts out as like a quest to be more healthy, but in that quest it becomes a little, exactly, an extreme. And then oftentimes, so orthorexia, someone might not necessarily be emaciated like an anorectic, and they are eating, but they're eating this very tightrope, you know, food plan. It's very narrow, it's very specific. We see a lot of gluten-free folks that do that, that got kind of crazy with like label reading and, you know, and they have no celiac or anything like that. They're just
came into my little boy's preschool.
Yeah, yeah. And I do think we're seeing more of it because, you know, you go to Barnes & Noble and you pull, you know, one of the food books off the shelf, you know, and you can get a little crazy, like, oh, I need to be gluten-free. And, oh, no, I need to be, you know, plant-based. Oh, no, I need to be paleo. Oh, no, I get, you know, I mean, and pretty soon they just start creating this very narrow road of like, I've got to just follow this, you know, which makes family gatherings really, you know, uncomfortable. So this, I love this little continuum, although it does, there's a couple of things that are missing, but it can help sometimes for a couple of reasons, kind of visual of how these eating disorders go along the weight continuum. You know, you would expect that folks that are anorectic to be less weight, folks with binge eating disorder to have more weight. The other thing that can be helpful is to recognize that these symptoms kind of go back and forth. You know, nobody is ever just anorectic or just a restrictor or just a binge and purger. People go through seasons or phases where they're engaging in various behaviors. But the other really important thing to recognize is that not every obese person is a binge eater. And not every thin person is anorectic, right? Which is tricky. Because sometimes we might see folks and right away kind of make an assessment or a judgment about kind of where they might be falling based on their weight. You know, I used to get tons until I think kind of the word got out that I wasn't so open to it, tons of obese referrals. And and their physicians are just assuming they had an eating disorder. But they weren't really doing anything super inappropriate, right? They might be overeating at times, they maybe weren't as active, but they certainly weren't binge eating, as I would define binge eating. And so we have to be a little bit careful, but it does flow on this continuum. And weight will flow too, meaning that folks that fall in that middle category, bulimics, do tend to fluctuate weight fairly quickly, and over time, they might have like every size of clothes in their closet because there's times when their bulimia might be more anorectic in nature, more restrictive, or sometimes might be more binging in nature and more indulgent. And so then their size also kind of fluctuates along that time frame, all that continuum. Okay, I'm not going to go through all these. All this to say that, and this, I have another slide for males, but I didn't include it because I thought it was kind of boring. Because unfortunately, our research is way more focused on females because that's 90% of the population that I deal with. But just to be able to point out that there's some pretty significant research evidence that there's a strong connection between how women feel about exercise, how women feel about their bodies and how they feel about exercise, right? And not always in a positive correlation. And also I think it's really significant that this study's been repeated several times, that women who exercise primarily for appearance are actually more dissatisfied with their bodies. It means and are, sorry about that. And at risk for more eating and exercise problems. It may seem sort of obvious, but we do tend to perpetuate that notion that, wow, exercise is really great for your appearance, and a lot of women do get into exercise because of appearance. It's not very effective long term. Women that exercise for weight loss or appearance tend to exercise for shorter periods of time and they don't tend to stay with it. And it's also not very effective in terms of actually producing those positive effects. And in the meantime, they might develop more eating problems from it. So, but just to be mindful of the fact that how we do think about our bodies and how we approach that connection of how I feel about my body and how I exercise does make a difference. So let's talk a little bit about signs and symptoms of unhealthy, or what I would call unbalanced. And again, in my realm, one of the things I'm always looking for is unbalance, right? I hate the word unhealthy or healthy because in my realm, with the folks that I work with, it's not a useful term, right? All of my patients think they're being healthy. They're all trying to be healthy, but it's not healthy, obviously, if they're in my office. So I like the thought of unbalanced. I'm not even upset if people are exercising sort of in the extreme, or that's a huge part of their life and it's really important, as long as it's balanced. And we'll talk about that a little bit. But so signs and symptoms that exercise is problematic, and this is from a study that was done in '99. So if exercise is the individual's primary means of coping, so you have folks who are saying, it's the only thing I do for stress management. Now again, it's not a problem if you're exercising as a part of a stress management program, but if it's the only way that you ever achieve relief or some emotional support, it can be problematic because it's just too much placed on this one activity. If exercise occurs despite injury, and then also if there are withdrawal effects, if there's mood swings, if there's actually sleep appetite shifts when exercise is withheld, then we start becoming concerned that type of exercise that they're doing is either, it's not mitigated with healthy eating or other psychological kinds of supports, or it really is just falls straight up unhealthy. Here's these are more signs and symptoms not related to that particular study, and these are not going to sound strange to you. I'm sure they're very familiar. Overuse, stress fractures, menstrual irregularity. One thing about that, the old adage that elite athletes lose their periods and that's pretty normal and we just expect that, is like done. Nobody believes that anymore. And I should give credit, pretty much everything I know about exercise and eating disorders comes from Ron Thompson and Roberta Sherman, who are the two folks, they're actually down in Bloomington, And they have written tons about eating disorders, athletes. They're on the Olympic Committee. They wrote the NCAA standards. Like, they know what they're doing. And every research that's come out in the last 10 years says women must have periods, period. So it doesn't matter if you're an elite athlete, it doesn't matter if you're just an exerciser, that losing your period means something is really wrong. And what we know now too is that there are long-term, very negative consequences from not having a period. So we put that up there because a lot of times, you know, people say, well, that's just the way my body is. You know, during sports season, I just lose my period, but it comes back, you know, when I'm done running, or, you know, if the season's over. Yeah, we don't do that anymore. Yeah, don't accept that excuse. It really is. It's actually part of the NCAA standard now that if a coach knows that one of their female team members is not having a period, they need to be on injured reserve until that returns.
What's usually the cause of that? Like, they're not getting enough calories? They're not...
Yep. There's, we call it the athletic triad. So if there is an imbalance of energy, meaning there's not enough calories coming in, and that can also be too much overtraining, you know, so they might have enough calories to kind of sustain them, but they're doing so much overtraining that it starts really wearing on the bone. And then we get bone loss, you know, bone density problems. Sometimes if there's a reduction in calories, what will happen is the body will start pulling from the bone for nutrition. So then you get bone density issues, and then that leads to osteoporosis. You know, if you're having hormonal trouble, then that is also gonna, you know, facilitate that. But usually it's because there's not enough fat in the body to sustain pregnancy, so the body just sort of like thinks, oh, we don't need this cycle. It might just be that there's not enough energy coming in to maintain that cycle. You also lose your immune system or your respiratory system or your circulatory system. Most of my patients that are anorectic have very poor circulation, and it's because the body just doesn't have enough calories coming in to sustain all those systems. Our bodies are actually really smart, so pretty much without even telling it, it'll conserve, and it will make sure your brain, your heart, and your lungs get what it needs. So if you reduce your calories, you know, essentially either reducing calories or doing too much, you know, activity, your body's going to say brain, heart, and lungs get all the calories and nothing else. So obviously a menstrual cycle doesn't seem so vital, so it's one of the first things to let loose. So so then obviously loss of bone density, decreased immunity, frequent colds, all these things, you know, overtraining syndrome, which is, you know, you're training but you're not getting any better performance, even though you're working harder and you're doing more exercise, your statistics aren't improving at all. All those are signs that, you know, perhaps there's an imbalance. You know, either there's not enough food coming in to warrant the amount of activity that you're doing, or there's just way too much activity. And we'll do one more thing and then we'll pause for a second. So in assessing, you know, whether or not exercise is staying in the healthy realm, right, that it is a balanced thing, a couple of things we're looking at. One is just motivation for exercise. You know, what's the drive behind it? You know, is it healthy? And we can talk about this a little bit later too. Or is it more related to physical appearance or stress management or some sort of compensation, you know, for what I've eaten? The intensity of the exercise or the emotion associated with it. You know, I know when I even suggest to some of my folks that they cut back a little bit, the level of hostility that I get is pretty intense, you know? Or even just suggesting maybe you could do something else, you know? There's just an enormous, just a too much emotion wrapped around, you know, what I do. Flexibility of routine or schedule, you know, an inability to change that at all. I had a woman who went on a cruise recently, and she's on a cruise. She's in the Caribbean, her family's all there, they're doing all these things, and and I'm not exaggerating, of the waking moments during the day, she probably spent, you know, 5-6 hours a day in the gym of the cruise ship, you know, and her family was coming in saying, like, this is just not okay. You know, for 1 week, she could not just put it aside. So that inability to be flexible, you know, when it would be appropriate. How folks respond to injury, you know? If you have an injury, if you have a stress fracture or a tendon tear or something like that, and your response to that, you know, maybe you're very diligent with what medical recommendations are during the recovery period, but your exercise returns exactly the way that it was, you know, as soon as you get kind of the green light, that would be a concern for me, right? Like, okay, can we, you know, back up the bus and ask, how'd you get injured in the first place? What's going on with that? How people respond to an experience of an injury. And then just the satisfaction, you know, how do you feel about your fitness level? How do you feel about your body? And it's not to say that any one of these things, you know, is a problem, but when they start adding up, when you start having several of these showing up, you want to stop and say, wait a minute, this is getting to be an over-exercise problem. So we know that exercise is becoming a problem if it interrupts with the maintenance of good physical health, you know, because you're obviously going to have injury or it's problematic, or even just things like, you know, I've had several patients actually who were waking up in the middle of the night to go run, you know, 3, 4 in the morning and going out running in the dark, you know, where their physical well-being is in danger, you know, and then they're crashing at the end of the night, or they're not able to do their job well, you know, because of that. Obviously, it's getting in the way of that. Same with good psychological health. You know, you can tell if there's a compulsivity, if there's an obsessive quality that starts interrupting good psychological health. The maintenance of good relationships. Like I said, this woman who was on the cruise, her family was irritated with her the entire week, and it just caused all kinds of conflict and tensions. But that wasn't motivating for her to pull away from it. She just sort of tolerated those problems in the relationship. And just the practice of everyday activities, you know. I have patients that are missing school, you know, because they're ill. You know, if your respiratory system or your circulatory system is compromised, you know, if your immune system is compromised, you're gonna get sick. And so then they stop missing, or they start missing really important activities like work, sport, you know, because they want to keep exercising. And so like we were talking about before, there's these two categories, right? So those are over-exercising. That's a concern. It's something that we might need, you know, to tend to or address. But when it starts needing treatment, it takes on sort of a different category. So if a person cannot not exercise, right? Meaning for whatever reason, my schedule, my school, my family, whatever, I'm on a cruise, something would dictate that I need to take a rest day and I just can't do it. That's an indicator that something needs to be addressed, something's going on. If a person exercises despite injury or on medical advice not to exercise, or if the relationship between eating and exercise is an unhealthy one. So like I was saying earlier, if there's an imbalance, if I am exercising a lot, but I'm not willing to feed myself enough for that exercise, obviously these are layers at which something needs to be done. And it's not just, I think, within their capacity to change, it needs treatment. It needs more of a full boat, full-on intervention. And, and similarly, you know, when these exercise, when the over-exercising is not just over-exercising, but is actually part of the symptomatology of an eating disorder, there's obviously a line there, and here's the things that I'm looking for. If it's used to compensate for eating, you know, so if you hear someone say, oh, I ate way too much tonight, so I have to go run, you know, and my folks will do that in a way that's pretty clearly distorted. For instance, you know, it's 10 o'clock at night, and you know, I have a patient who actually gets in bed and then starts recounting all the things that she ate during the day and has to get out of bed and go do some exercise to kind of, or she can't sleep, you know, because it's just that connected. If I ate, you know, an extra dessert or something, I have to go do extra activity. So that kind of math that starts lining up, that there's always this compensatory quality. Same thing in the reverse. If exercise starts to legitimize eating, well, I ran today, so therefore I can eat something I don't normally let myself eat. Or I can eat way more, and again, it becomes a symptom of the eating disorder because it can justify the binging, because that balance becomes about compensating for really unhealthy psychological eating, which obviously can be it's an eating disorder symptom. If eating is used to reward exercise, right? I have a lot of trouble with this with some of my binge eater patients who, I went for a walk today, so therefore I can, it's like, wow, it's just suddenly all open for me. It legitimizes that strategy. And you're kind of probably getting a sense here. One of the things that we try to do is keep eating and exercise in two separate categories and not so intertwined. So it's fine if you have a strategy and a plan for how you want to eat, and it's fine if you have a plan and a strategy for how you want to exercise, but when those two things start being tied, that's where the risk factor into the eating disorder realm kicks in. If you're obviously using it to maintain an unhealthy negative energy balance, meaning I'm exercising more when I know I'm not eating very much, then if you're doing that intentionally, that's an eating disorder symptom. Or if you're using your dissatisfaction with your size, shape, weight, or fitness level to rationalize excessive training, when in reality, you're already pretty just fine fitness-wise. This is, again, I run into this a lot with my teenagers. I tell teenagers all the time, like, if you want to exercise, that's great, it's fine, but in reality, you actually are getting quite a bit of activity. I have a lot of teenagers that talk to me like they're a 50-year-old woman, where they feel like, oh, if I don't go exercise right after school today, I'm going to gain weight, or I have to do that. And I'm like, your metabolism is actually really great. Enjoy it while it's there.
Do you see a lot of that being like fed by a parent, or like just what they're heard, what they hear in their household at all?
I mean, some, yeah.
Is there trends on that at all?
Yeah, there's the research about girls with eating disorders having mothers with eating disorders is really horrifying. It's pretty, there's a lot of that.
Mm-hmm.
Part of that is also because it is genetic. There's a strong genetic component with eating disorders. Not every girl can develop an eating disorder, even if the situation is perfectly ripe. In fact, I'll tell you the very best thing that's happened in the last 10, 15 years in the realm is that we started cluing in to the biology of an eating disorder instead of just approaching it from a psychological perspective. We went 20 some years ago when I started this, we had our best treatment effort was about 30% effective. And which is terrible if you think about it. Mm-hmm. And in the last 10 or 15 years, I would say our best treatment approaches are about 90% effective. And the simple change, in my opinion, is biology. So we're looking at things like genetic. Like if you have a mom or an aunt or someone in your family that had an eating disorder, you gotta be really careful. Much like if you have a relative that's an alcoholic. If I was an alcoholic, I would not be sending my kid down to IU and saying, good luck. I'd say, you need to know, you carry the gene, dude. Like you can't binge drink like maybe some other people that can. And I would say the same thing if someone has an eating disorder in their family history. I would be like, you can't diet. You got to be really careful because we never know when that flips the switch into the eating disorder realm. And it can be something as simple as a weight loss or a dieting experience or just getting more into exercise or sport. And so, one of the things that we've looked at is, okay, if you're an adult woman and you've struggled with some of these issues, how you talk to your daughter, how you set it up. Some of it is just environmental, but some of it is just you're perpetuating that biology. Mm-hmm. So really being able to interrupt that has been enormously helpful. Mm-hmm. So.
What about like past trauma that someone goes through? Do you think that?
Oh yeah. Yeah, I mean, there again, that's another alarming statistics, is that girls with eating disorders have a much higher percentage of trauma in their history. And part of that, is because trauma can change your biology as well, but also it creates this environment of unsafety. And one of the things that an eating disorder does is give someone a sense of safety and a sense of control because I'm tolerating it, I'm handling it, I'm managing what I'm doing. And it also allows them to stay a bit numb, because if I'm not eating or I'm over-exercising, I'm not as in touch with what's going on with my body. And so it's actually rather helpful, if someone's had a trauma, typically their eating behaviors or their exercise behaviors help them stay a little bit removed from that reality, which is why when they come in for therapy, it usually kind of is rough and they get more anxious and they get more agitated. It's really difficult, but if they can tolerate the process, they get better. But yeah, absolutely. So I do want to, I think this is where I want to stop a minute, just to kind of talk about things you've seen, or, yeah, we can stay here. Things you've seen, concerns you have, kind of differentiating, like when to step in or when to get concerned. Do you feel like you have a sense of that? Is there anything about this that you're like, that's crap, that's everyone we see, you know, what's your sense? Where's the line at which you guys would get concerned?
Well, and I think part of why we wanted to bring this up was, a big piece was, I guess we are not clear on that line, and if it's something we would address with our fitness specialist, which is, I mean, us here, we're talking mainly about their fitness levels. We don't dig a whole lot, which I really like that assessment up there, you know. We don't really dig into the psychology a ton, nor do we their diet.
Right.
I mean, we ask basic questions, but we're not registered dietitians. We work with Laura Jordan, who would probably see a lot more and be able to analyze this better than and I don't know if I'm wrong or right. So ours is more of an assumption, or if we're training people, then we're getting to know them a lot better. And you're like, okay, this is a red flag, because or we train them and then they continue to work out when you've given them a great workout already. You know?
Right, yeah, and that's a great litmus test, is if there's compliance. You're working with a professional, you're asking me, you know, what I think, I've set up a specific program for you and your fitness goals, and you're somehow going outside the lines, you know? To me, that's like a great way to intervene. Like, do you want to know what I think? Do you want to work with me? You know, or even just, what's the motivation? What's making it hard for you to trust that the plan I gave you is enough?
Well, we hear a lot about, I mean, and I could be wrong, and they would know a little bit better than me, but I hear a lot of talk about weight and not necessarily health.
Right.
It's more about that number that they're focused on.
Right.
I mean, we have a different age group that's more about, you know, their health, but I think that average, and I would say it's been more of an issue here in this location, that I've really noticed that scale and that don't miss.
And for me, I worry about when we should say something, but then also how we should say something. And so I'm coming from this I'm certainly not an expert in your field. I'm also not a fitness expert, and I was late to the meeting today, so I'm really coming into this blind.
Who are you?
But my concern would be, are we speaking about this in the proper way?
Right.
Certainly, I don't want to do more harm than good.
Right.
We just don't want to blurt out, hey, I think you got a problem. You know, like.
Right. We've had moms that, you know, Kelly has brought up to me and saying this, you know, the baby's barely 6 weeks. It really, and they're dropping it off at our busiest times. It's like a red flag outside, and they're pumping in here like, oh, here you go. And it could be just a stress reliever, which is what I'm like, I don't know how to decipher that, you know, so, and we really didn't have a contact of what to do.
Sure, okay.
And it's also hard to know, like, on what level they are. I think a lot of just general public people come in with maybe like body image issues, or like Sarah said, a lot of it isn't talked about, like weight. And so maybe there's like signs, but we don't know kind of where they're at in that.
Right.
And then also, I think sometimes people that are a little bit more extreme, they might not come to us and say, hey, I want a trainer, hey, can I go through an assessment? They're a little bit more withdrawn, and they're kind of doing their own thing in the corner 5 days a week for 2 hours.
Right.
So it's hard there to know, like, do you go up to them and say, you know, hey, how's it going?
You're not going to get a great response. Yeah, you're right. Yeah, because you're exactly right. And this is one of the other difficulties is it is such a personal preference, and you're stepping into someone's, you know, they've already done their own sort of soul searching about, like, this is how I want to spend my time, this is what I want to do, don't tell me how to do that, whatever. So, well, let's talk about what, or, you know. So yeah, I mean, I want to be clear, like, I do think the line is tricky, but the more that there's a difference between recognizing, yeah, that isn't really what we're supporting here or what we want to be about, and when do I need to like intervene. But I think if you guys at least know where the line is in terms of what we are trying to support here and what we believe collectively is healthy exercise, I think, you know, you're always going to have people that use a place like this inappropriately. You can't help that. And if they're not dying, like I said, and they don't have a diagnosable issue, it is a kind of gray area. But if you are collectively understanding this is what healthy exercise is and this is what we want to promote, that's the best thing that you can do. And it will either trickle down to those folks, you know, and sometimes they do glean that, or there may be times when other people who do know them better could step in and say, you know, I was in this class and he or she was talking about it and it seems like you're not following that or whatever. You know, it's not just up to you guys, you know, that the more that the whole place has sort of a healthy perspective, that does trickle, you know. But so, how to address it. And the other thing is what I want to be clear about, and again, we're going to get to the whole like specifics, but these are just some things that when people come to my office and they're struggling with exercise or eating or whatever, these are the things we're looking at, that I'm looking at. I don't even expect you guys to do this, but I think it's helpful if you know what they would get in treatment so that you kind of support that, especially if you ever have someone that you're working with that clearly has identifiable issues. We want to be on the same page. So changing the person's attitudes and beliefs about exercise. I mean, this may seem obvious, but to confront, like, you have an unhealthy perspective about that, and we need to like realign that. So giving accurate information, emphasizing that healthy exercise means healthy nutrition, you know, they go hand in hand. Exercise for health, not for the purpose of losing weight, you know, primarily, like you said, even though that filters in. Changing the relationship between eating and exercise so that it's not compensatory, that it's more balanced, interrupting that pattern of using exercise to compensate, and again, redefining health. And then this I think is really important, especially for those of you that work directly with clients. Increase body awareness while decreasing body obsessiveness. Body awareness is a great thing. You know, learning to recognize hunger, satiety, fatigue, you know, any of those signals, you know, I'm kind of feeling sick today, I'm feeling kind of out of it. Those are really helpful things that folks that tend to exercise obsessively struggle with. Because like I said earlier, obsessive exercise kind of numbs some of those experiences. And especially for somebody in the eating disorder category, they have very little body cues. You know, most of my patients that are struggling with an eating disorder have very little contact with what's going on in their body. So the more that we can kind of help people focus on how do you want to feel in your fitness level, not necessarily how you want to look. You know, it helps them tune into their body awareness without being so obsessive about how does it have to be and what does it have to look like and how many inches did I lose and all of that. It's much more about being in touch and aware. Does that make sense, that differential? And then, you know, assisting people in meeting needs previously met or associated with exercise. So if it is stress management, like I said, that's not a terrible thing to be, you know, active in the stress management realm with exercise, but not to be the only thing, you know. So even saying like, okay, if previously you were using exercise to compensate for eating, let's talk about doing healthier eating, right? So instead of just constantly making up for it, let's separate that, you know, stick to your exercise regimen, and then let's talk about how you might eat in a way that feels good all by itself so that the two don't have to be linked. Or maybe even self-esteem, you know, or just compulsion, like I just have to scratch that itch, you know, I have to go exercise. Okay, well, is there another way that you can kind of satisfy that need to go do something? You know, it might be, I'm always telling folks, like, change it up. You know, if you're always doing a particular type of exercise, do something active, but that's a partner thing, or that's a sport, rather than just on a treadmill or on a machine. So it still might be meeting a need, but not in the way that that compulsive, difficult exercise was. And then being mindful of your own attitudes, perceptions, language, you know, I mean, it's hard, you know, it's really hard. One, because we live in this culture, but secondly, because when you have a client, especially a client that is overweight, come to you and say, I really want to lose weight, it's really hard not to align with them around that, you know, because you know that healthy exercise and healthy eating can and probably will help them manage that weight. It's really hard not to give into that seduction, to be like, okay, let's make that happen, you know, this could be great, and it's so motivating at first. But like I was telling you in those studies earlier, if it's about weight loss or it's about how they look, the long-term effect of that is actually pretty terrible. They don't actually follow through. I wish I had the citation, but there was a study done, this was a while ago, I think it was actually done by the Weight Watchers people, which they didn't publish it because it wasn't really good for them. But if it took people who, they had two different population groups. Half the study dieted and exercised, and half the study just exercised. And then they asked, like, okay, who lost more weight and kept it off longer? Well, you would assume the diet and exercise people would. Well, the diet and exercise people lost weight quicker, but they gained it all back. And they stopped doing some of the things that were good for them. The exercise alone people lost more weight over time and kept it off. And part of that was because what they tuned into is that diet and exercisers, when they went off their diet, they also went off their exercise. So the exercisers just learned how to consistently be active. So we separated out the food and the eating, and they were a lot more successful. So creating, but the problem is that you know, we've been trained for many, many years. Lose weight by, you know, cutting your calories and increasing your intake. And so really giving them a different way of thinking about it. Like, you know, it's just healthy. Like, maybe your food isn't so great right now. Let's just work on, you know, moving and feeling better in your body and enjoying this activity. And, you know, I wouldn't say this to them outright, but they're going to be more successful down the road because that's something, it's also measurable. At the end of the week, I can say, hey, I went and I was active this many more times this week versus, oh, I didn't really lose any weight yet. And that tends to be so discouraging. But it's seductive because initially it's super motivating. You know, I feel so great and I'm doing it and I'm gung-ho and all that. And then 6 weeks into it, they're like, it's not so fun anymore. And then it just kind of falls away. So be careful about your own attitudes. Be careful about your own perceptions because they do tend to either make or break how that goes. So intervening when you see a problem, we'll go through these. Not your job to diagnose or treat. I don't want you to feel like a burden of, if I notice something or identify it, it's on me. And because it can make work really uncomfortable if you walk into the gym and you see that person in the corner doing their own thing. I'm like, oh. You know, that isn't your job, right? You have to have some, I'm sure they sign waivers, and people do have to be responsible for their own well-being, right? But I think one of the biggest things that I would say is if you are going to intervene, if you are going to approach somebody, please make sure you have a relationship with that person. I don't find it very effective to confront people you don't know. It just never goes well. I had a patient years ago who had a really well-meaning woman accost her in the grocery store every time she went there. And she looked awful. In fact, she actually died from her eating disorder. And she looked terrible, but every single time she was in the grocery store, this woman would, like, she was a woman that worked there, would pull her aside and say, you're dying, you need to do something. Never ever did anything for her except make her mad, right? But a trusted friend pulled her aside and said, you know, can we have a conversation? She listened to her. And so I would say the very first line of defense is if you notice somebody in your space that you're concerned about, build a relationship with that person. You know, even if it's just a relationship here. You know, if you're a trainer, just say, hey, what are you working on? What are you doing? I'm curious about what your strategy is or whatever. You know, if you really think somebody is in trouble, going at it sort of from a cold, you know, non-relational perspective is probably not going to be very effective. So I always want to make that disclaimer. Once you have that, it doesn't have to be like they're your best friend, but some sort of relationship. Reduce the shame and judgment. You want to pull them into a private conversation. You want to do it in an office. You want to pull them in because doing it out in the arena is just, you know, patients with eating disorders and problematic exercise are super embarrassed and shameful, and it will just flatten them, and they won't be able to hear what you're saying because they'll be too busy defending against the shame. And there isn't judgment. I mean, these are significant, serious problems that people don't wake up in the morning trying to develop, right? So to be able to be kind and supportive and loving and non-judgmental about, like, we just want to help you. You know, we just want to see if we can kind of steer this in another direction. Sharing observations, concerns, feelings, information, and doing it directly. I don't think it helps to do it indirectly. You have to do the face-to-face. But, you know, someone can't argue with your concerns or observations, you know. Now, they can argue your diagnosis, you know. So if you say, hey, we think you have a problem, or we think you're exercising too much, that is not effective. But if you say, hey, I've been here 5 days a week because I, you know, work here, but you've also been here 5 days a week, you know, or, you know, I have, you know, been here a lot lately and I haven't seen you take a rest day, you know, even in marathon training, you got to take a rest day, you know. That's an observation, right? And it's, you can't argue with that. So those are the kinds of things that tend to be really, really helpful. Hey, you know, I kind of noticed you're a little red in the face, and I'm wondering if you're checking your heart rate once in a while. I'm wondering if you're going a little bit too hard. I'm worried about you. You know, I've had other folks here who struggled or whatever, and I don't want that to happen to you. Those kinds of observations. Your feelings are legit. If somebody's making you nervous, go with that. You have a right to your feelings to say to somebody, I gotta be honest, you're making me kind of nervous. You know, I see you in here. I've noticed you've lost quite a bit of weight. I don't know what's going on with you. I'm not trying to step into that, but I'm nervous. I care about you. You know, I think these are the kinds of comments that are incredibly significant. Now, a person with an eating disorder especially is not going to say, thank you. I'm going to go take that up with my therapist. No, they're going to say, you're full of shit. Leave me alone. I know what I'm doing. I can't tell you over the years, probably every one of my patients that has ever been confronted about something like that is mad as hops when they come in my office. You know, you won't believe what my trainer said. And yeah, they think they can tell me, and they can't tell me, and they don't know. And but then at the end of all that, I'm like, okay, but are they right? Well, yeah, but okay then. Let's take the information and go from there. But I will say those kinds of honest, direct sharing of feelings and observation, those are the kinds of comments that later patients say, you know, wow, she was right, and I needed to do something with that, you know. And don't be afraid of the confrontation or the conflict that arises. It should be conflictual. I mean, they're doing something that's destructive for them, supportive and helpful, you know, to some degree, but not healthy. And I feel like people do appreciate that once the dust settles, because they do know that, you know, your agenda is not to be in competition or to stop them from having a good life. You want to keep them safe. And then I really think one of the best things that you can focus on are what I would call global interventions, which are not specific to each individual person. I mean, the reality is that the opportunities you might have to speak to somebody who actually has an eating disorder are fairly infrequent, but the opportunity that you might have to kind of promote, you know, a mentality and an attitude that would help everybody is a lot, right? So sometimes if you have that thought, you know, we don't always know who around us has an eating disorder or who's being triggered by certain things. So that's why I said watch your language, watch how you're talking, even about your own diet and exercise, you know. Folks with eating disorders don't always look like they have an eating disorder. I have lots of patients who actually look overweight, but they definitely have an eating disorder, and they are definitely struggling, and they are like just absolutely hypersensitive to that kind of language. And it does make a difference, you know, they hear it. And so those global interventions that, you know, help everyone feel more positive and better are very protective of them too. So global interventions would be things like, you know, scheduling information sessions, you know, for everyone. Like, hey, we're gonna have someone come in and talk about, you know, what it means to be female, or how to manage stress, or self-esteem, healthy body care, body image, you know. I used to do a body image workshop. Used to work at Memorial, and I used to do body image workshops, and mostly it was nurses who would come, you know. And very few of the folks that came had eating disorders, but the fact that the hospital was putting up these flyers and that there were these regular workshops gave the impression to a lot of people, hey, you know, they care about this stuff here. It's not just about like the, you know, the January weight loss competition. You know, we also care about the other things. Pamphlets, posters, same sort of thing. You know, what you put out kind of, it communicates something different. articles, what kinds of things do you make available? You might find that your folks that are sort of in a precarious situation are going to be very reticent to like pick up a pamphlet or pick up an article, but the very fact that they know they're there, I'm telling you, I hear this in my office all the time, oh my gosh, like it's Eating Disorders Awareness Week and my gym put up a poster and I think everyone's looking at me and I'm like, well, maybe they should be looking at you, maybe they do know, maybe they're worried, and those kinds of things intervene. They make people stop and think like, am I doing that? I need to take a step back. And yeah, role modeling, healthy attitudes about weight, eating, exercise, self-acceptance. Though the more that you do that, you start creating that ripple effect so that it's not even just about having to address this one person, you're addressing everybody, and it's good for everybody, but the person with the issue is hearing it, but you don't have to single them out to be able to make that happen.